So my presentation today, I'm going to speak about cancer and autoimmune diseases. And I'm posing a question, is it a tale of two immunological opposites or not? I was inspired to prepare this lecture because really I've been seeing many patients with autoimmune diseases. And when I see the patients and I examine them, I find that their condition, their condition regarding the musculoskeletal system is fine. However, the ESR is very high, usually it exceeds the 90s, and the C-reactive protein is extremely positive. And when I ask the patient, do you have any other problems or issues which is alarming? The question simply is no. When I dig more and I ask at night pains, for example, I ask about loss of weight, I ask about anorexia, and then the patient will start to say, sometimes I have anorexia, sometimes I've lost some of weight, and so on. At that stage, I assume that this patient, especially if he's an old patient, and I consider old patients more than the 50 years of age, that this patient had another disease in addition to the autoimmune disease which I'm treating. I used to do tumor markers, and then at a certain stage, I used to do a bone scan. Sometimes, if I'm lucky, I get metastasis on the bone scan, at which stage the disease has been really there for a long time. So what I thought of, we should have a vision that there's a relation between cancer and autoimmune rheumatic diseases, because it is the autoimmune system or the immune system who is driving the two processes together. One of them preceding the other, or the other one is coming after the first one has occurred. And usually autoimmune rheumatic disease occur first and then the cancer. But with the development of treatment for cancer, like the checkpoint inhibitors, immunological change can occur and autoimmune diseases will result. So we know now more knowledge about the epidemiology of the diseases, the pathogenesis, and the long-term outcome of the rheumatic disease, how it will end up to. And there are therapies which treat cancer, and at the same time therapies which treat autoimmune diseases, and the therapies which treat cancer can lead to autoimmune rheumatic diseases. And this في حد بيتكلم ولا صوت ايكو ولا ايه؟ الثانية؟ Okay. And the drugs which treat the autoimmune rheumatic diseases can cause complications as well. So we have the risk now of development of malignancies in patients with many systemic rheumatic diseases when we compare it to the general population. So we have to be very vigilant about this. Autoimmune diseases, we know that immune intolerance occurs, and the patient immune system starts to attack the patient's systems as well. And it is failure of the defensive mechanisms of the immune system. And the immune system sometimes does not respond to the malignant cells because it is overwhelmed by the immunological process taking place at the rheumatic disease. So for many years, you have considered that autoimmunity and cancer as two separate fields in research, but usually they have something in common. But with the discovery of the new drugs, especially the checkpoint inhibitors, and the development of anti-cancer drugs like PDA, programmed cell death receptor 1, and CTLA4, cytotoxic T lymphocyte antigen, they proved that studying autoimmune diseases can be extremely helpful for developing new novel anti-cancer treatment. So I'm posing a question, how does the immune system respond to cancer? When the immune system finds a cancer, it sounds the alarm, activates its troops to fight it. However, three possible mechanisms can occur. The immune system wins, kills the cancer, and you never know that there was a cancer there. The second scenario, the immune system tries its best, but the cancer grows too fast and the cancer develops and progresses. The third scenario, which is the most probable one, that the immune system gets very confused because it is already a diseased and abnormal immune system, and it starts attacking the body systems as well, in addition to the musculoskeletal systems. So we ask another question: do autoimmune diseases increase the risk of cancer? They can increase the risk of cancer in many different ways. They cause chronic inflammation, the autoimmune disease, and this will stimulate cancer growth. Inflammation can change the cell's DNA and will allow the cells to respond quickly and form cancers and multiply. The other thing is increased vascularity. Inflammation can increase blood vessels, and this will lead to growth, and this will feed the cancer. Certain autoimmune disease can make it for the body to clear the viruses that cause the cancer. A typical example is papilloma, which cause cervical cancer. Certain treatment of autoimmune diseases can increase cancer risk by depleting the body from its cancer defense mechanism. And this is very common because we use glucocorticoids, we use so many immunosuppressive drugs. So I'm going to speak today about 5 topics: cellular and effector molecule involvement in cancer, rheumatic disease that are associated with increased cancer, treatment of rheumatic diseases and development of cancer, cancer screening in patients with rheumatic diseases, and the takeaway message. So my first part is the cellular immunity, or the cellular part of the autoimmune system and the cancer. We have proposed a classification early of chronic diseases, and we agreed that it can be pro-inflammatory based on the extent of the regulatory T cells. The most important cell in the whole process is the T regulatory cells, the T lymphocytes. So it's either Tregs, which is high Treg, or low Treg. This classification was useful in the following. We can understand the efficacy of drugs for the treatment of different chronic disease. We can explain the association of specific chronic diseases with specific pathogens. We can interpret the effects of different pathogens in cancer and the autoimmune disease. So here we reach that those two diseases, they run parallel, hand in hand, and each of them affects the other one. During its course of growth, the cancer will progress from a pre-inflammatory low Treg disease to an anti-inflammatory high Treg disease. So we have the two together. In the early stage, it's a low Treg disease, and in the later stage, it is a high Treg disease. Many autoimmune diseases are characterized by decreased T regulatory cell function, and this will lead to a pro-inflammatory low Treg chronic disease. Reactive oxygen species will come to the screen and they will come to the field, and they exert two opposite effects. Some of them are promoting autoimmune rheumatic diseases, and some of them are advancing the cancer. So reactive oxygen species are well as the Tregs playing a role. For all these reasons, autoimmune rheumatic diseases and advanced cancer can be considered two immunological opposites. The involvement of the T cell is very important, and this is a typical example of pro-inflammatory chronic disease. Treg function is impaired in autoimmune diseases. In particular, T helper 1, T helper 17, they are involved in the pathogenesis of many autoimmune rheumatic diseases. T helper 17 frequency and function increase in multiple sclerosis, psoriasis, rheumatoid arthritis, inflammatory bowel disease, and SLE. While T helper 2 cells mediate allergic immune responses and they play a pathogenic role in systemic sclerosis and ulcerative colitis. So CD8, cluster developed 8 cells, they attack cancer cells directly, and at the same time they destroy the cancer cells through the release of perforin and the fast apoptosis pathway. So the CD8 cells are very important in attacking the cancer cells. The Tregs they suppress the function of the CD8, and thus they promote cancer and inhibit the proliferation of the T cells, memory cells, and the effector cells such as T helper 1. T helper 17 will display T helper an pro or anti-tumor role within the tumor microenvironment, which has been reported in many cancers, including renal cell carcinoma, ovarian cancer, endometrial cancer, hepatocellular cancer, and oral squamous cell carcinoma. Now these are, I'm going to enumerate the cells and the cytokines which are involved. We have autoimmune regulatory cells, we have cytotoxic T lymphocytes, and we have programmed cell death receptors. Also, we have programmed cell death ligand, and we have T lymphocytic activator, TLA, and you have T cell immunoreceptor with immunological 3, TIM3, and you have transforming growth factor beta, and you have interleukin, and arginase, ARG1, and lymphocyte activation gene. The next slide I'm going to show to you, I put this first because the next slide is really very, very busy. It's a very busy slide, but it shows you that if you are a healthy person and there are all these cells, there are B-reg, T-reg, M2 macrophages, and the MDSC, which is myeloid deprived suppressor cells. If they increase, they will cause cancer. And if they decrease, they will cause an autoimmune disease. So in between, there's a healthy person which can develop either each. So the whole idea that they are phased or connected together through very autoimmune complicated mechanisms. So if we start by mutation of the cells, there is a defect in the repair and apoptosis defect. This will lead to an autoimmune disorder. At the same time, with paraneoplastic diseases, we have a reduced cell tolerance. On the other hand, inflammation coming from the autoimmune diseases will release cytokines, and the result trigger unregulated cell proliferation. It will lead to chronic inflammation, B cell activation, intolerant anti-self, tissue immune response, and exaggerated damage. Cancer will cause paraneoplasia, and paraneoplasia will cause an autoimmune disease. So it's a very complicated situation, but it is connected through the immune system together. So my second we ask ourselves a question. Do rheumatic disease associated with increased the risk of cancer? Certain rheumatic diseases, like inflammatory myopathies in particular, they are most recognized for increased rates of malignancy, a wide spectrum of rheumatic diseases, and association with cancer. On the other hand, some cancers appear to be increased across multiple autoimmune diseases. For example, we know that non-Hodgkin lymphoma, which was reported to be associated with 21 different autoimmune diseases in the Swedish register. We will review the risk of cancers and some of the autoimmune diseases. What is the mechanism to explain increased cancer risk? Several mechanisms have been proposed. One theory that naturally occurring immune responses against cancer can trigger autoimmunity. The patient can start having cancer or a malignancy or a tumor, and then comes on top of it an autoimmune rheumatic disease. And this can trigger autoimmunity and rheumatic disease, which explains hypothetically the short interval cancer development. Especially, we have two important diseases which malignancy occur very quickly, is myositis and scleroderma. In scleroderma, patients who have anti-polymerase 3 or anti-RNPC3 antibodies, they have an increased risk of tumors and malignancy. In patients where rheumatic disease precedes cancer development, Inflammation and tissue damage from chronic autoimmunity leads to malignancy because the body and the immune system cannot clear the remnants of the inflammation and the inflammatory markers are increased. In Sjogren's syndrome, having a high ULAR Sjogren disease activity index at time of diagnosis has been associated with increased lymphoma risk. At the same time, patients with scleroderma-associated interstitial lung disease, this is a very common finding in patients with scleroderma, and there is an increased risk of lung cancer in those patients. Finally, ability, because the body cannot, or the immune system, cannot clear the viral infection, what happens there is that this predisposes the patient to autoimmune diseases and cancer. For example, in SLE patients, certain cancers are increased, like human papilloma virus associated tumors to be increased in such case. On the other hand, there are hormone-related cancers. For example, if we take the breast cancer, there is an increased development or increased risk of breast cancer in systemic lupus erythematosus and inflammatory bowel disease. If we take osteosarcoma, thyroid autoimmunity, and diffuse scleroderma, increased risk of developing cancer, risk of developing autoimmune disease at the same time, like rheumatoid arthritis, spondyloarthropathy, Stevens-Johnson syndrome, and autoimmune hepatitis. So if we have a cancer, like osteosarcoma, there is a risk of developing autoimmune disease. If you have a cervical cancer, there is a risk of developing ankylosing, Kawasaki, polymyositis, and rheumatoid arthritis. If you have a prostate cancer in patients with systemic lupus or type 1 diabetes, there is low risk of developing cancer, while there is an increased risk of developing autoimmune disorders, and the typical example is rheumatoid arthritis. So what are the rheumatic diseases? What are associated with increased risk of cancer? The first one is idiopathic inflammatory myopathy. Patients with this disease have an increased evidence of certain cancers. The highest risk of cancer development is in 3 to 5 years before the disease or after the disease, which is very important. This disease can present to start with as malignancy, and then you will have the idiopathic inflammatory myopathy, and it can occur 3 to 5 years even after the occurrence of the disease. Adenocarcinomas are the most commonly associated tumor type and may affect the ovaries, the gastrointestinal tract, the lung, or the breast. Patients with rheumatoid انتوا شايفين اللي تحت ده طبعا have a 5 to 0.5 fold increase in the risk of cancer, while those with polymyositis, not dermatomyositis, the incidence is less, 1 to 0.6 folds. If we take systemic sclerosis, tumor types that are seen at a higher risk than the general population, they include the lung, the liver, the cerebral cavity, thyroid, and so on. At the same time, the risk of breast cancer is elevated around the time of scleroderma onset among patients with diffuse scleroderma RNA polymerase antibodies. If we take rheumatoid arthritis, the registers occurs in 1978. They started talking about the incidence of malignancies in rheumatoid arthritis. The increased risk is up to 10% in the overall malignancy. The risk of lung cancer as well as lymphoma was greatly increased. In contrast, the risk of colorectal cancer and breast cancer was decreased. We have one explanation for the colorectal cancer why it is decreased, and the only explanation that, if you remember, patients who are taking non-steroidal, especially COX, selective COX inhibitors, they have a lower incidence of colorectal cancer. And this is the only explanation I can find in the literature. Other theories postulate the increased incidence of certain cancers in rheumatoid, have a common factor, because with smoking, there is a risk factor for both rheumatoid arthritis and lung cancer. Elevated inflammatory biomarkers such as ESR and C-reactive protein are an indicator of the occurrence of cancer. The disease, the longer the disease duration, the administration of corticosteroid were linked to lower lymphoma risk. And then Sjogren syndrome, the risk is higher in Sjogren syndrome than in general population, especially non-Hodgkin lymphoma, 13 to 18 times higher than the rate of the general population. There are primary B-cell lymphoma, which can be found in mucosa-associated, what we call mild lymphoma. Increased risk of thyroid cancer can also be seen, while in disease like systemic lupus erythematosus, the overall risk of developing malignancy is slightly higher than that of the general population. The rate of non-Hodgkin lymphoma is increased in SLE, and the rate of HPV, papillomavirus associated cancer, such as cervical and valvular cancer, has been elevated. Patients with SLE have a lower risk of breast cancer and prostate cancer than in the general population. Polymyalgia rheumatic and genital arthritis, the risk is slightly increased. At the same time, in ANCA-associated vasculitis, GPA, higher risk of cancer, cancer of the urinary tract, leukemia, and non-melanoma skin cancer. So to sum up the whole thing, we have a shared etiology. Common including exposure. For example, these are the environmental risk factors: smoking, infections, and shared genetic susceptibility. If we start here with the systemic rheumatic disease, there's a chronic inflammation. Tissue damage induced by the disease will lead failure of the immune tolerance and the production of cytokines and chemokines. Inability to clear the oncogenic viral infection, which is very important because the immune system is disturbed and confused, so it cannot clear this. There is an immune dysfunction. Prolonged immunosuppression, which we usually do with our patients by anti-rheumatic drugs, immune dysregulation will occur. This will proceed to malignancy. And then in malignancy, there's chemotherapy, radiation therapy, immunotherapy, and this will increase the incidence of autoimmune rheumatic disease. There's vascular toxicity and neurotoxicity, triggering of severe skin thickening, priming and amplification of the host immune responses, and the release of cytokines and chemokines with oncogenic inflammation. This is what occurs with in malignancy, what we call oncogenic inflammation, lymphocyte infiltration, local antigen, and so on. And then the vicious circle will continue. You start with one disease, you land in another disease, so they are two opposite to each other. أنا طولت عليكم بس I hope ان انا حاولت ابسطها على قد ما اقدر. لغايه امبارح بالليل كنت ببسطها. So if we speak about autoimmune thyroiditis like Hashimoto's, we have thyroid cancer, breast cancer, lung cancer, and digestive system. Systemic lupus erythematosus, we have lymphoma, breast cancer, lung cancer, cervical cancer, mixed connective tissue disease, skin cancer. In rheumatoid arthritis, we have lymphoma, lung cancer, and skin cancer. In Sjogren, this takes the upper hand and the lead. Myopathies and Sjogren take the upper lead. Blood cancers, lung, thyroid, skin, and kidney. Now, the next part of my presentation, I'm going to speak about treatment of rheumatic disease and development of cancer. So what drugs we are using? They have two solid edges. One of them is doing benefit and the other edge is doing harm. Several medications we use in rheumatology are associated with malignancy. For example, we'll take the first one is cyclophosphamide. In granulomatosis GPA, the risk of both bladder cancer, leukemia increases with cumulative doses, and the dose is very high, 36 grams, and this is very alarming. I don't think we reach this dose, but this is what has been documented because most of these data are coming from the registers. Smoking and prior episodes of hemorrhagic cystitis, which we see very commonly with cyclophosphamide, predictive of urinary tract cancer in patients with vasculitis. In SLE, cervical intraepithelial neoplasia may be increased. Now, if we take the second drug, there is mycophenolate. This is a study from the heart transplant study because they give those patients mycophenolate. It's not from rheumatological. They showed that the risk of malignancy is lower. If we take another drug, azathioprine, seemed to be associated with developing cutaneous squamous cell carcinoma after transplant. If we take methotrexate, which we use extensively, which is commonly used in our diseases, is associated with melanoma, skin cancer, NRA, psoriasis, and psoriatic arthritis. And then we come to the TNF inhibitors. There are several registers which have shown that there is no increased risk of melanoma for patients to TNF inhibitors, abatacept, tocilizumab, or rituximab. However, the risk of non-melanoma skin cancer is high to be increased with TNF inhibitors in both rheumatoid arthritis and psoriasis. Patients, this is new to me, I haven't seen it before. Patients on methotrexate, TNF inhibitors, azathioprine, and mycophenolate should wear some protective clothing or sunblock and should report any new persistent skin lesions or a change of appearance of all the skin lesions, in which case a skin cancer screening program may be appropriate. We never tell our patients to do this. اقصى حاجه بنقول للعيان البس نظاره لو عيانه عندها سيستميك لوبس، عندها هيلوسنسيتيفيتي، ولكن السكين نون ميلانوما سكين كانسر we can decrease its incidence by doing what they have recommended. Now انا طولت عليكم بس الحته اللي جايه the cancer screening is very important because this is what we should do. Patients with new onset rheumatic disease, especially who are old, who have a typical aggressive disease features, it's important to adopt the optimal approach to detect an underlying malignancy. When you are in doubt, have to examine the patient thoroughly, do investigations, whatever you would like to do, because it's a life-threatening disease having the two diseases together. In many studies, I used to do, as I mentioned before, bone scan. But what is recommended now is PET-CT, and this is what I'm using extensively now. When I have a patient with an old age, with a very high ESR, how disease, musculoskeletal disease is controlled, I usually order a PET scan. And one of the funny things I have seen, and I reported this in one or two cases, or more than that, generalized lymphadenopathy with rheumatoid arthritis, which has been documented in the literature. I don't know what is the significance. Is it a pre-neuroplastic or paraneoplastic? And I send those patients to an oncologist who would say, follow up, repeat the PET-CT after 6 months, let us see. Similar data evaluating cancer screening and other rheumatic diseases is lacking. We don't have, like I've shown you, some of the studies of the results coming from transplant documentation. So finally, I'm going to speak about my take-home message. Inflammation derives both autoimmune disease and early-stage cancer. Low or very high levels of reactive oxygen species induce autoimmunity. Some of them are pro-inflammatory and some of them are anti-inflammatory. Due to both effects, initiation of cancer and early growth is promoted by pre-existing autoimmune disease. So the pre-existing autoimmune disease will promote the occurrence of cancer growth, and at the same time, the spread is hindered in patients. If you have a patient with a pre-existing rheumatic disease and then he develops cancer, the progression is going to be improved survival and it will progress slowly. But if you have already a cancer and an autoimmune disease on top of it, the progression will be higher. Certain high-risk groups within rheumatic disease may benefit from intensive cancer screening, especially dermatomyositis. Agents used for the treatment can increase the risk of cancer, and on top of the list, cyclophosphamide and TNFs. On the other hand, patients who undergo treatment for malignancies may experience worsening of their rheumatic disease, especially with checkpoint inhibitors, because when they did the checkpoint inhibitors, when they discovered it and gave it to the patients, many autoimmune rheumatic diseases occurred. And lastly, the final thing, JAK inhibitors have, which target specific part of the immune system, their effect inducing malignancy is very controversial, especially some studies demonstrate the higher incidence of cancer, especially tocilizumab, and it has now a black box warning in 2022. So the whole idea of this presentation is one thing. I wanted to shed the light on the occurrence of autoimmune disease and malignancy, because usually when you are seeing a patient with an autoimmune disease, you are definitely very much focused on the disease itself, and you are overwhelmed by the disease. You are looking for the improvement signs and so on, but don't overlook a high ESR or a high C-reactive protein. Diabetes can be a risk factor, and check with the patient if there are any other complaints which are not related to the musculoskeletal system. I have discovered many cases of colorectal cancer, of cancer thyroid, of cancer breast, and I think I was very successful in getting these cases and documenting it. But I hope I'm disseminating this knowledge for you, because I think we should not overlook other diseases apart from our autoimmune rheumatic disease. Thank you very much. لو حد فيه عاوز يسأل أسئلة أنا تحت، بس أنا طولت تهيألي. أنا خدت قد إيه؟ نص ساعة ولا أكتر؟ أنا الحقيقة أنا اخترت التوبيك ده من أرض الواقع، لأن ده اللي إحنا بنشوفه. في عيانين كتير قوي بيجوا لنا، وإحنا بنبقى دايما فوكسنج على الجوينتس وال CRP والإي اس ار and so on, and we overlook any other accompanying disease. يعني في عيانه اللي انا لقيت عندها ايلوريكتال كانسر دي كان الاي اس ار بتاعها 94 وشي واز توتالي فري، مفيش اي جوينت انفليم. فقلت لها سرعه الترسيب العاليه دي ما تتناسبش مع حد. الاسبوعين اللي فاتوا كان عندي عيانه عندها 80 سنه، الاي اس ار اول ساعه كام؟ 125. فطبعا قلت ايه؟ مالجنسي، شيء من عند ربنا كده. قال لي عيد الاي اس ار. الست ما بتشكيش من اي حاجه، عدت الاي اس ار طلع 25. ف it is a very tricky situation. Thank you very much.